Good evening, and thank you all for joining us today. On behalf of Jagsonpal Pharmaceuticals, we welcome you all to the next Scientific Sangam 39, organized by ISOPARB Prayagraj in association with Allahabad Obs Gyn Society. We all are looking forward to esteemed international cricket lead Dr. Jagdish Gandhi, his masterclass on urinary incontinence today. Jagsonpal presents to you newly launched Epiprotein Pregnancy's Perfect Companion with the benefit of lactoferrin in pregnancy from first trimester until delivery. We also have Doxypal DRL, our doxycycline, 100 milligrams with lactobacillus to improve immunity and to restore ovulations and reproductive health in women. Cystelia-M, formulated with ideal 40:1 ratio of myoinositol and dechiroinositol. A warm and hearty welcome to all these esteemed faculty and attendees. Please note this webinar is streaming live on Facebook. The link will be shared in the chat for you to circulate. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. The organizing chairperson of Scientific Sangam series is Dr. Ranjana Khanna ma'am, founder and president of ISOPARB Prayagraj. She is president of FOXY 2017 and currently ICUG Governing Council member since 2020. Welcome, ma'am, and over to you to kindly initiate this session.
A very good evening to all the learned faculty and delegates. We will start the webinar after we pray to Lord Shiva. So please.
त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृतात् त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान् मृत्योर्मुक्षीयमामृतात्.
Very good evening to all the faculty and delegates, and a very good morning to you, Dr. Jagdish Gandhi, who is a consultant urogynecologist in Hull University, UK, and he has done his MBBS and MD from BJ Medical College, Ahmedabad, and he did his MRCOG from London. I welcome you all to this master class on urogynecology by Dr. Jagdish Gandhi, who is an expert in this super speciality. I welcome you, Dr. Gandhi, and extend my heartfelt gratitude to you for accepting my offer. This topic is extremely important but very less discussed. We often have elderly females who come to our clinic and they are very uncomfortable even while talking to us, and they become recluse and they prefer to stay at home. And because because the complaint is that when they cough or they sneeze or even they laugh out loud, then there is leakage of urine, and that wets their undergarments. So in India, these patients are actually who come to our clinics are the tip of the iceberg, because the problem is much more than that. Most of the females avoid going to the doctor because they feel actually ashamed, as if they have done something wrong. So this is a very, very important problem, and we have nobody but the expert, Dr. Jagdish Gandhi, who's going to clear all our doubts. And now I will begin this webinar by inviting our chief guest, Dr. Usha Sharma, madam. May I have a CV, please? Padma Shri Dr. Usha Sharma, ma'am. She was awarded Padma Shri by the President of India in 19 85. And she has performed so many laparoscopic surgeries, and she was given a laparoscope by the late Prime Minister Indira Gandhi herself. So many awards to her credit. She is the chief patron of UPCOG, and we are so proud of Madam because she has excelled in all the spheres possible. She is a teacher of teachers and extremely, what to say, she's so learned, and she is ex-Director General Medical Education, UP, Principal cum Professor of Gynecology and Obstetrics, LLRM Medical College, Meerut, and Chief Patron, as I've told you. And during MBBS, ma'am, you must be remembering those days now, distinction in anatomy, physiology, pharmacology, pathology, juris, and OBGYN, and President of India's Medal for Best Medical Girl Student of India in 1965. So, welcome, madam, and please give your blessings to this webinar.
Thank you very much, Ranjana. I really appreciate that you are organizing these master classes in various subjects, and today we are having master class in urinary incontinence under the banner of Scientific Sangam 39. But Ranjana, I have a feeling to share with you. You should not name it as Scientific Sangam. I think it's a Sangam of academic feast as well as an association of very dynamic, dedicated, hardworking, and I can say very talented persons like Dr. P.K. Shah, who has been our President Foxy, Dr. Madhuri Patel, who is Secretary General Foxy, as well as Chief Editor of Jogi. And we have got two very sweet, loving ladies, Dr. Leela Vyas, as well as Dr. Komal Chavan. आ गई कोमल, अच्छा दिख नहीं रही थी. Komal Chavan, whom I always appreciate and admire. They are such loving and affectionate persons. And then you have chosen your scientific expert as Manju Verma, who is very close to my heart, and you know she is a strong pillar of UPCOG, as well as Dr. Chaurasia, who is an expert and a neurosurgeon. And then I cannot forget Amita Tripathi, who is convener of the program, and co-convener, we have got Uma Jaiswal as well as Parul with us. You know, today it's very, very important because I feel you have chosen a really, as you said, that urinary incontinence is a very important topic, but least discussed. Yes. And especially, we are discussing the topic today by the expert from UK, Dr. Jagdish Gandhi, whose caliber and competence all of us know. And it's a great pleasure that we have been able to have him for this talk on urinary incontinence in elderly women management, as well as non-mesh method for the management. Now, all of us know that urinary incontinence is an age-old problem. Initially, the menopausal women were referred to as itchy, sweaty, as well as wetty due to the repeated voiding of the urine. And sometimes there was discharge of urine before they could reach the washroom to void the urine. These all things were really very, very saddening for the patient, as well as they were really very much frustrated about it. But with the increasing awareness, as well as with the newer modalities of testing for these urinary problems like uroflowmetric studies, these are the devices, these are the investigation or the treatment part, newer devices by which we can have solution of these problems. And I really think that these things are very important these days, and the problems are having such a great magnitude that now we are having another specialty known as urogynecology. So we have to deal with all all these things. We know that there are TOT meshes, which are a permanent solution for the stress incontinence, but certainly there are certain complications like erosions and other risks which are really alarming. And Ranjana, I really congratulate you to organize such a scientific webinar program. It is a wonderful program and will really tell us, and especially by Dr. Jagdish Gandhi, we will know the challenges of managing urinary incontinence in elderly women, as well as non-mesh methods of dealing with these problems. And I'm sure that today the deliberation of Dr. Jagdish Gandhi will go a long way in updating the knowledge of every one of us and will be opening a new vista of management in the field of urogynecology and their problems. I wish this program a great success. Thank you very much, Ranjana, for making me a part of such a prestigious event. I wish you all a very healthy, happy, and bright future. Thank you very much.
Thank you so much, madam. I loved your words of blessing. And now I would like to invite our guest of honor, Dr. P.K. Shah, sir, who is a teacher of teachers and an extremely deft and efficient surgeon. And he has been past president of Foxy, professor and unit head department of OBGYN and LTM Medical College and LTMG Hospital, Sion, Mumbai, SATE and the KEM Hospital, past president of Foxy, IAGE, IFUMB, MOGS and AFTT.
Enough,
And
Ranjana.
Hanji.
Enough.
And of course, he has got so many awards, given so many orations, and I believe he's an excellent surgeon because his student, Dr. Niranjan Chauhan, keeps on praising him. So, and I keep on hearing. So, Dr. P.K. Shah, I would love you to say a bit about Dr. Gandhi and give your blessings to this webinar.
Sure. Thank you very much, Dr. Anjana Khanna, the organizing chair of this webinar, Scientific Sangam 39, organized by ISOPARB Prayagraj in association with Allahabad Obs Gyn Society. And very rightly said, the master class on urinary incontinence, what you always wanted to know. It's a great honor to be sharing this platform with none other than Padma Shri Madam Usha Sharma and my colleague Dr. Madhuri Patel, who is a very good friend from Foxy, who is the Secretary General. You have chosen the real master teacher for this master class, Dr. Jagdish Gandhi. I am his maternal uncle, but we passed out MD at the same time. He passed out from BJ Medical College, Ahmedabad, and I passed out from KEM Hospital, Mumbai. I visited him at Hull, at his place twice. We stayed with him and we roamed around so many places around Hull. Not only that, following all AICOGs lately, his family, my family, and two more friends' family, we go together for some outing in India or abroad. Immediately after passing out MD, he decided to go to England. And since then, for last almost, I feel, 45 years or so, he has been there. And he is an expert urogynec surgeon. So nice to have him here. And we are all eager to listen to you, Jagdish. Also, it's nice to have an expert in urogynec like Dr. Dilip Chaurasia, who is with us. And the two chairpersons, Dr. Leela Vyas, Dr. Komal Chauhan. Also, it is nice to see that scientific expert Dr. Manju Verma is also with us, and the organizing secretary and convener, Dr. Amita Tripathi, co-conveners, Dr. Uma Jaishwal, Dr. Parul Khanna, and Dr. Kavita Barnwal, who is the chairperson of Urogynec Committee of Foxy, and Dr. Shubha Pandey, who is the president of OBGYN Society of Allahabad OBGYN. Now, already Dr. Ranjana Khanna has told you that what we see, the number of cases in our practice of SUI is tip of iceberg. Very true. Today, let me tell you honestly, every alternate house, if you see, you will find a woman with SUI. Unfortunately, they don't go to doctors. They feel that it's a normal and natural thing in menopause, and they suffer it silently. I think there is a need for Foxy to have some sort of a public awareness programs in all these places in local language to make all these ladies realize that it is something which is treatable. It can be managed with or without surgery. So I think a very important thing one should, I hope Madhuri is listening to me, but we should take up this issue very seriously and see that all these women who are suffering in silence, they are treated by all of us. Thank you very much, Ranjana, for inviting me to be the guest of honor. And it's nice to hear my own relative. Normally, we keep talking and discuss obviously a lot of OBGYN, but it's nice to hear him for almost 2 hours on subjects like challenges in managing urinary incontinence in elderly and non-mesh options for management of SUI. There are a lot of controversies regarding mesh, and I'm sure it will be cleared by my dear friend, more of a friend than relative, Dr. Jagdish Gandhi. Thank you very much and wish you all the very best for all your future programs, Ranjana.
Thank you so much, Dr. Shah. Thanks a lot. And now I would welcome the other guest of honor, Dr. Madhuri Patel. Has she joined?
Ma'am, I think she's not able to join, ma'am. Dobara do teen link bheja, but I can't see her.
Call her
Okay,
up,
in the
na?
meanwhile, I
Rika.
warmly welcome our two chairpersons,
Yeah.
Dr. Komal Chavan, who is VP elect Foxy and who was chairperson of the Medical Disorders Committee of Foxy, and Dr. Leela Vyas, who is VP Foxy 2018. Both are great academicians, and we would like to hear from them. And I also welcome Dr. Dilip Chaurasia, who is a professor and HOD in the Department of Neurosurgery, MLN Medical College. And I would also welcome Dr. Kavita Barnwal, who is chairperson of Foxy Committee, Urogynae Committee. And nice of you, Dr. Kavita, also to participate as a faculty. And I would welcome our very own Dr. Manju Verma, ma'am, who is a scientific expert. And in fact, I, along with our whole team of ISOPARB Prayagraj and Allahabad Obs Gyn Society, welcome all of you to this prestigious webinar in which we have a wonderful speaker, Dr. Jagdish Gandhi. Has Dr. Madhuri joined?
Hey, ma'am, kuch
Ma'am, not
glitches
yet. I've sent her the Zoom ID also.
Okay.
Yes,
So,
thank you so
I
much,
think she'll
madam,
be
for
joining.
welcoming all of us.
You're
It's always a
welcome,
pleasure
Komal.
to
You're
be
really
here
welcome.
and take blessings from Usha Sharma, madam, and Dr. PK Shah, sir. And it is honor to chair the session.
Of
by
course, you're
a
going to
very, very
become vice
distinguished-
president now, na? In
Yes,
Jan?
Elect.
in January.
Elect.
Hey,
And you all
January
have
she'll
done
become.
मैडम भी अभी आई भी है अभी
Niranjan
भी
आ
will
रही है.
take. I
लॉर्ड
will
Hi,
डाउन
take.
को
Dr.
इंस्टॉल हो गया
Niranjan. How
हाय
are you?
निरंजन हाय
Thank you.
आ
I'm
गई
honored.
एक हफ्ते की 10 दिन की बात है
Oh,
क्या
I thought
we'll
I
have
was
a
speaking
great party
without Dr. Niranjan's knowledge when I said that he keeps on praising Dr. PK Shah and I keep on listening.
And he was there after many days. We are together in a car going back home. So I think it was a right moment.
So,
So-
should we start?
Yes, ma'am.
So I now hand over the proceedings to Dr. Amita Tripathi, our overzealous, energetic, meticulous, dynamic honorary secretary of ISOPARB Prayagraj. Over to you, Amita.
Thank you, Ranjana ma'am, for praises and a very warm welcome and good evening to the 39th edition of Scientific Sangam. It's a proud privilege for ISOPARB Prayagraj along with AOGS that Dr. Jagdish Gandhi today is with us, and he's going to speak on very important and his favorite topic. So without wasting our time, we are going to start our scientific session. And to chair the session, we have two very special chairpersons, Dr. Leela Vyas, Madam, and Dr. Komal Chauhan. Can I have CV of Dr. Leela Vyas? Dr. Leela Vyas has been Vice President Foxy 2018. She is former Senior Professor and Unit Head, IVF Consultant, and member of Research Review Board, SMS Medical College, Jaipur. Senior Consultant, Aesthetic and Cosmetic Gynecology at Vyas Clinic, Jaipur. She's the Director of Hope Hospital, Jaipur. And she's Dakshata and Lakshya Mentor NHM, Rajasthan. Director of Manyata CSC, Rajasthan Vish. And she has been on various organizational positions. Welcome, ma'am. And I have CV of Dr. Komal also. And as everybody has told, that Dr. Komal is joining as Vice President Foxy in 2025. Dr. Komal ka CV? Yes. She's Medical Director, Chavan Maternity and Nursing Home, Senior Consultant, DNB Teacher, and Unit Chief, VN Desai Hospital, Mumbai. She has been Chairperson of Foxy Medical Disorder and Pregnancy Committee 2019 and 2022. And she has won various prizes and awards. To name few, Dr. Rishma Dhillon Pai Personality Award and Dr. N.A. Pandit and Mrs. Shalja Pandit Women Empowerment Award of 2022. Welcome, Dr. Komal. And today, as an expert, Dr. Dilip Chaurasia is also joining us. And Dr. Dilip Chaurasia, may I have a CV of Dr. Dilip Chaurasia? Yep. Dr. Dilip Chaurasia has established Department of Urology and MLN Medical College, Allahabad. He is right now Head of Department Urology, MLN Medical College, Allahabad. He has organized various conferences like NZU SECON 2008, UAECon 2019, conducted StoneCon workshop under the aegis of AUU. So welcome, Dr. Dilip. And with this, I will request Dr. Leela Vyas to kindly introduce our speaker, Dr. Jagdish Gandhi, sir. Can we have a CV of Dr. Jagdish Gandhi?
At the outset, I convey my sincere thanks to ISOPARB team Allahabad, especially Dr. Ranjana Khanna, and very good friend of mine. She always remembers me in putting here and there and calling for the various. सबसे पहले मैं प्रणाम करती हूँ हमारे सबसे सीनियर मैडम उषा शर्मा मैम को. मैम आपकी ब्लेसिंग सब में मिलती रहे, देन भी मतलब हम लोगों का कहते हैं ना, दिन बन जाता है, जीवन बन जाता है. PK Shah sir, thank you very much for your kind words, and always you remember us, and to join with you on the webinar, it's a pleasure for us. And sir, just one information to you. I've again joined one of the medical college in Jaipur. Not that, it is a Gitanjali Medical College. That is as a head of department. Sir ने मुझे एक college के लिए मना किया था, उसमें मैं कभी नहीं गई. Thank you sir for your advice. And all our friends, Manju madam, I welcome you. That you are a scientific expert, we all know. You are flooded with the knowledge. Then organizing secretary, Amrita, really thank you very much. Uma, and they are all good friends. And then Parul is there. And again, with Dr. Kavita Baranwal, she is the chairperson of this Urogynaecologist committee, really, and she will be, it's a very good friend of ours, and definitely she will also put her inputs in that. Now, the guest speaker, Dr. Jagdish Gandhi. I think we are very old friends. We are meeting every time. And really, I always praise, and Madam Mrs. Gandhi, Madam is also there. So we have become like only of that, the old Foxians meeting every time. And regarding his CV, he's graduate from the India. And then कहते हैं ना कि हमारे हिंदुस्तानी जाके जब बाहर नाम कमाते हैं तो वो एक हमारे लिए प्राउड उसमें होता है. So we are proud of that. You are working there. So you are RCOG Tier 3 educator in the postgraduates, OBGY medical education and trainings, fellow of the Royal College of the Gynecology, membership of the examiner in the RCOG London, and extensive experience in training in urogynecology, invited speaker and faculty at all, many of the international conferences, operating faculty at international workshops in Urogynae, and editor of the Indian Obstetrics and Gynae Journal, editorial member. And sir, really we have seen you to operating, we have heard you that, and we always love to listen you. And sir, really, you always blessed us with your knowledge, and also whenever you are coming to meeting you, it gives a means कहते हैं ना वो बहुत means जो होता है it's like elder brother and all. You always meet us, and we welcome you in this platform, and definitely will get benefited by your all this knowledge, and that you will give the guidelines to us to how to treat the elderly. The topic I'm not going, everyone has said that it is a unspoken problem, and which we have to make out and then to treat our patient to help them. Thank you, sir. Now I invite Dr. Jagdish Gandhi, sir, to deliver his lecture.
Thank you very much. I'm just going to share my screen. Can you see the screen okay?
Yes, sir, we can see.
Yeah, we can see.
Okay. First and foremost, many thanks for involving me in such a prestigious event. I do really appreciate. Morning and evenings are different in UK and here and in India, but it's real pleasure. My special thanks goes to dear friend Dr. Ranjana and her team. We started journey a while ago, and when it converted into friendship, I really don't know. Only thing I know is my wife is much more fond of Dr. Ranjana, and she really enjoys interaction with her. So thank you very much, Dr. Ranjana. I wouldn't go individually thanking everybody, but I do appreciate the efforts you make. And what I can't believe is the scientific platforms that you are organizing from not just one state, but from so many centers. It's amazing. It's really, I'm going to have a little memory lane in between two topics, and we will talk a little bit more at that time, but I'm really proud of my home country. And of course, adopted country. So today, I'm going to talk initially about managing urinary incontinence elderly. I'm Jagdish, the consultant urogynecologist and lead at Hull University Teaching Hospital. Hull is in East Yorkshire. Very often when I interact, people are not quite aware of where. But if you look at the map of India and superimpose onto the England, where there is a Delhi, it's a Scotland area, where there is a Mumbai, that's the Manchester area, where there is a Chennai, it's the London area, and where there is a Kolkata is our East Yorkshire Hull area. So that is northeast where we are west. So structure of presentation, initially I'll touch base on basics in urogynecology. I can't expect everybody to be on board, and that is the reason why I'm just going to touch base, which will include types of incontinence, causes, diagnosis, investigation, and then the current management options. Once we have done that, that will give us much more clear idea about how we're going to talk and manage elderly incontinent women, and what are the challenges and what strategy we should adopt for the management. Now, I'm very pleased to say that this is about 25-year-old slide, but still it is true. As Dr. Ranjana and Usha ma'am touch based, it's a big problem. And let me tell my best phrase, which I use regarding incontinence. I think God must be man. And the reason as a gynecologist I feel is why God gave only 4-5 centimeter urethra to women and 20 centimeter to men. The only design fault I can find in human body is urethra. And truly speaking, this was the old technique of crossing the legs, but with advances we have, many things can be done. And people don't have to suffer in silence. It really breaks my heart when I see people, and it's not just in India where people are just hiding, but here also in UK, number of people, they are suffering with incontinence is unbelievable. I will present some statistics in epidemiology later on, but basically, yes, there's a vast suffering. So everybody knows about type of incontinence, stress, urge, and mixed incontinence. Now, depending on which survey you take, it's roughly 1/3-ish. Some people will say stress incontinence is a bit more. Again, it is more commoner in probably younger. Urge is more commoner in older, and mixed could be anywhere. Now, the basic neurophysiology, if you look at the brain, which has got the cerebral cortex, and it interprets the messages of full or empty bladder. And in the spinal cord, at the beginning, there is a pontine maturation center, and that switches between voiding and storage. At the lower level, at T10 and 12, we have got hypogastric nerve, which takes the impulses out to the bladder and takes impulses in. It's a sympathetic, and it inhibits the detrusor contractions during the storage or filling phase. And once you are ready, the pelvic nerve, which is parasympathetic, and it unopposed impulses results in detrusor contraction, and at the same time, the somatic voluntary control from pudendal nerve relaxes the sphincter and the pelvic floor, and the voiding takes place. Now, the mechanism of continence during the bladder filling, the urine storage, it leads to bladder accommodating by increasing volume. It doesn't increase the pressure in the volume. And the example I always quote is, if you are putting the air into a football, the pressure will start increasing because football can't expand. But two organs in our body, stomach and bladder, are such that they expand without increasing the pressure. And this is the base when we do our urodynamic study. So due to the smooth muscles activity, it is suppressed by a centrally mediated neural reflex. And to maintain the continence, what is required? The bladder outlet and urethra must be closed, and the relaxation in the bladder itself. Now, in normal bladder emptying, what happens is there is a decrease in urethral resistance. It opens up, and pelvic floor gets relaxed, and funneling of the bladder outlet, and that leads to opening and starting of bladder emptying. Now, the mechanism of incontinence, we saw the continence mechanism, how it is controlled. Now, incontinence, what happens? When there's a pressure within the bladder exceeds urethral resistance, for example, in coughing, sneezing, etc., and the anatomy and function of either bladder or urethra changes. So there is a urethral weakness, or there is a more detrusor overactivity. And this will result in overfunction or underfunction. And that will lead to urinary incontinence. Bladder overactivity obviously is urge incontinence. Underactivity is overflow. And if urethra is overactive and remains closed, it's again overflow. And urethra, if it is underactive, weak, it's a stress incontinence. The commonest scenario, as you know, is bladder overactivity and urethral underactivity. Putting them in picture, pathophysiology, the urethra becomes hypermobile. It moves down beyond the pelvic floor. And when abdominal pressure increases, it can't have that support, and it leads to incontinence. Again, my belief about God being man, not man being God, is gender is one of the commonest reasons for stress incontinence. Childbirth and obesity, they are the predominant, but there are several other risk factors, and that includes the pregnancy, menopause, cognitive impairment, and advanced age. One of the other common phrase which I use to make people understand, because people come with a lot of expectation that everything will be sorted. And all I need to say is that, well, ma'am, I'm sorry, it's wrinkles on the face, which is the aging process. And the same thing happens to the connective tissue around the bladder and urethra. Again, as I mentioned, there is a pressure increases when there is a overactive bladder. So what we call compliance. Normally, as I give you example of football, when air goes in, pressure increases. Normally, in normal bladder, when urine gets collected, pressure increases, but because muscle relaxes, pressure doesn't go high. However, with detrusor overactivity, bladder does not relax. In other words, it's a poor compliance. It doesn't follow the normal rule of our physiology, and that pressure increases, and that is seen on urodynamic studies. And similarly, when there's a pressure in the bladder from overactivity goes more than urethral pressure, you get the incontinence. Stress incontinence, what's the mechanism? Here, there's a pressure, intra-abdominal or otherwise, and when the pressure increases and it bypasses the urethral pressure, at that time, you have got a urinary leakage. So what do you do about this thing? To start with, of course, symptom assessment. Stress incontinence is physical provocation. And I do like about detrusor instability. It's a fun. If your bladder has got fun, you don't have fun. And what does fun means? Fun is frequency, urgency, and nocturia. So if you remember fun, if somebody has got fun symptoms, you immediately think about overactive bladder, and you are likely to be 80-90% success in your diagnosis. And patient's perception. Now, as you know, as social classes changes, some people, they have got very high expectation about the incontinence. And very rightly, even few drops of water leakage once a year when they are playing tennis or horse riding, it is disaster for them. We have got another section in our community here in UK, or in Hull, I should say, my city, where people are quite happy changing 6 pads a day, which are all measuring more than 200 mils of urine. So almost they're passing in that. But that is patient's perception. And they will still say that, doctor, I'm all right. Doctor, I'm all right. And what Ranjana ma'am was saying and Dr. Pikesha was saying, that there is so much awareness required that something can be done about it. And I would completely agree that this is a project, we should take it. That reminds me about a very funny film, and I'm sure so many of you would have watched. It's called Padman. And I think we need to tell Akshay Kumar to make another film, some similar to that one. And that will take the whole of message very, very quickly in the community. That's this is not a taboo. It is a medical condition and it can be addressed. It can't be cured, but it can be helped. Quality of life questionnaire is something which we use, and the International Continence Society as well as IUGA, they have made out various questionnaire for stress incontinence. It's a short questionnaire and long questionnaire, and similarly for urgent incontinence, a short and long questionnaire, vaginal symptoms questionnaire. For bowel, there is a questionnaire, and sexual health questionnaire. So there are many of them, and they can be available on IUGA website as well. And they're useful just to compare from what happened in the past and what's happening now once you're given the treatment. The examination wise, everybody knows we need to rule out any retention by abdominal examination and neurological examination, as well as vaginal examination to rule out any prolapse or any masses. Asking the patient about stress incontinence and urgent incontinence, I would like to share a couple of very basic questions which will immediately give you some insight. And as I said, that these are the two common mechanisms of incontinence. And once you have established, then line of management will become easier. So You ask that during the last week, how many times did you accidentally leak urine with a physical activity like coughing, sneezing, lifting, and exercising, or a feeling of strong, sudden need to pass urine that did not allow you to reach to the toilet. So the first one is stress incontinence, and the second one is urgent continence. Now, perhaps as you know, even when you cough, sometimes it creates contractions in the bladder, and that will lead a leakage. And then it becomes difficult to say that it's a stress incontinence or urgent continence. Now, another trick which I have learned over years is to ask a very simple question. Madam, do you drop out water when we're asking about leakage, or do you flood? If they say that they are having a small amount drop out, that is likely to be stress incontinence, because the mechanism is such that it will be like a leaking tape, slow few drops. If they say they are flooding out, that means it's a massive detrusor contractions which empties the bladder completely. So a very basic trick, 2 questions. If there is a fun with flood out, it's likely to be overactive bladder. If it's a stress incontinence, which is dropping out, it's likely to be stress incontinence diagnosis. Again, this is the fun, and look at it. Either you have got toilet in the office or office in the toilet. And so many people, when you give them bladder diary, they will come up about 20 times a day passing water. So every 40 minutes, 1 hour interval, that is terrible. Physical examination. So on abdominal examination, you want to rule out any mass, and on pelvic examination, atrophic prolapse, mass, voluntary pelvic floor contractions. Out of all, atrophy is something which you must address it, because atrophy is so much associated with overactive bladder for 2 reasons. One is vaginal irritation because of atrophic vaginitis, and the second is you do need a small amount of estrogen for the urothelium to keep it going. And that is where treating the overactive bladder and atrophic vaginitis together gives best result. You don't need to start medication straight away, but do start, say, atrophy treatment, and there will be a massive improvement. Other reason why atrophy is so important is because of the vaginal irritation, one's mind is always around that area. They can't do anything about vaginal irritation, but then they can go and pass water. And then the bladder has got its own brain, and it will start going and passing water more and more and more frequently. Rectal examination, you want to make sure that there's no mass, tone is okay, and the anal sphincter contraction, looking at it, anal reflexes, and looking at the anal wink when you taste it, or clitoral irritation. So that's something. The sacral neurological sensation, reflex, and foot movement. Again, as I said, that's test for anal wink and foot movement. Now, out of all the investigations we do, if I have to pick up one, I will pick up urinary diary. Urinary diary never lies unless people have filled it wrongly. It will tell you about the time and volume of all the voids. It will tell you about the bladder capacity, which is about 200 to 300 mils, and mean volume, how much you are storing. Frequency is about 8 times a day. Now, I like the B for bladder, because if you look at B and if you look at 8, it resembles. And this is the magic number. Usually the frequency is 8 for the bladder. And that will help, especially to women, to remember that, yes, bladder is number 8. Nocturia, it will tell, and leakage episodes. And most importantly, it will not exaggerate. I had a patient who will say, oh, I can go and pass water every 15 minutes. This morning I went and passed about 8 times. And when we gave her diary, so when we calculated every hour 4 times, that's in 12 hours, it's about 50 times a day. And she said, yes, yes, yes. When we give the diary, it came down to about 12 to 15 times. So people do perceive that they have got frequency, but not necessarily all the time. Investigations, the simple one, urine analysis, because UTI can mimic very much to the overactive bladder symptoms. You need to rule it out. And the pad test, again, that can give you some idea. You can give the dry pad to use it for one day, and then you measure it, weigh it next day, and that will give you idea how much is the loss. Ultrasound scan will give you idea whether there is a overflow or post-void residual urine. And uroflowmetry, they are the more invasive test, but they will give idea if there's a obstruction. As you know, normally in women, the obstruction, urethral obstruction is uncommon. It's not like men. Invasive investigations, urodynamics. Madam Usha did mention about such a brilliant test. I remember very first time when I came to UK, I was a house officer in urology. And in 1980-81, those time when we were doing urodynamics, the machine was so basic. It was a drip from the from IV fluid, and the tubes and everything was so basic, but the principle was solid. And it did give us idea about recording bladder pressure during filling and voiding phase. And that was giving some idea about detrusor overactivity. If there are contractions, when patient is trying to inhibit micturition, and that's most important, you tell patients that you're not going to pass urine or try to hold it on. For stress incontinence, which I'm sure that my colleagues of similar age group will remember, it was used to be called genuine stress incontinence. And obviously, this was politically not correct because patient will feel that, well, am I not genuinely telling you stress incontinence? And of course, it is a urodynamic stress incontinence is the current definition. Cystoscopy is required in few people where there's an unexplained hematuria or when you are suspecting a small bladder volume. And this is one of our ex-staff, Paula, and she was from Scotland, brilliant physicist. So in urodynamic study, we do have a physicist who is handling the medical equipment, etc. And then you have got a nursing assistant, and then the consultant who is doing the test itself and interpreting. So we have to ask her, good morning. And probably you know that people from north of England or north of UK, they do have quite good chatting power. And for next 2 hours, I don't have to say anything, and she will just keep going nicely. Now, in the set itself, this is the urodynamic machine, and this is for flow. So once you have connected the catheter in the bladder, and there's a sensor on the machine itself, and then the similarly catheter in the bowel or in the rectum, and you again join it. You make sure that it is done and measured, calculated, calibrated against the atmospheric pressure, because as you know, even at rest, bladder has got some pressure because of intra-abdominal pressure, and you want to do it at atmospheric pressure, and then they come and sit, you start filling the bladder and watch what contractions or what is happening. And this is a typical graph showing the detrusor contraction. So this line is the total pressure from the abdominal as well as bladder muscle pressure. And this one is the rectal pressure. And when you subtract from total pressure, rectal pressure, you get actual detrusor pressure. Normally, the detrusor muscle will stay just at the baseline, probably maybe about 10 to 15 centimeter water pressure. But here you can see it's going right up to 60 and 80. These are the bladder contractions. So they are the detrusor contractions. And with these contractions, you can see here, there is a leakage. So this is the flow of urine. And here, again, is the leakage when there is a massive contraction. So this is the evidence that yes, she has got reservoir activity. Now, how do you manage? As we were discussing before, simple thing first. You don't need to have very fancy medications. You don't need to have a lot of operating thing. Simple thing. And I'll give you the examples, practical examples from each of these things. Advised modification of fluid intake. I had a very young woman. Her complaint was when she was playing on trampolina, and you know, when you jump on trampolina, you go up, and she will say, yes, I go up, but when I come down, me and my V both comes down. We said, fine, okay, let's see what's happening. Give her bladder chart, and she was used to drink 4.5 liters to 5 liters. Now, if you imagine, that means it's about 400 mils an hour drink. That means about 5-6 mils of water every minute. And you can imagine it will, how much it will produce. No doubt. So give her simple measures to say, right, madam, drink only 1.5 to 2 liters. And her symptoms were cured nicely. So such simple things help. Alter medication. Patient will come and complain that, oh God, I have to wake up 3 times during the night and I can't sleep, and so on and so forth. You check their medication. She's on diuretics. Because she can remember only at night, she takes diuretics at night. And you have got problem solved once you say that, no, ma'am, you take it in the morning. Treating UTI, very simple thing. And respiratory condition, optimize the chronic conditions, asthma, bronchitis, and so on. Constipation is another one. Fortunately, in Asian subcontinent, we don't have that big problem of constipation. But here in UK, the British bowel are completely, you will not believe. And some of the stories I hear, I can't believe. One of the very youngish women came, and when I was taking history, that what's your bowel habit? And you will not be surprised, majority of women will say that, well, I open 3-4 times a week. Fine. This woman was other way around. She was opening bowel at 3 to 4 weeks interval, approximately once a month, or at the most twice a month. So I had to sit with her and say that, okay, ma'am, you are eating 3 times a day. And every day you are eating probably 300-400 grams of milk. 3 times it will be a 1 kilogram, 2 pounds worth of milk. What happens in 30 days? It is nearly 30 kilogram that you have ate. Where does it all go? And then you're complaining about putting on weight. And then penny drop. And she said, oh yes, I need to do something. The other thing which happens with the constipation is you have got the collection in the lower part of the bowel, in rectum and anal area. And as you know, bladder and bowel anatomically are very close. Here, of course, in India, we use different terminology for houses like a bungalow and duplex and so on. Here, when there are individual house, it's called detached house. And when there are 2 houses together, it's called semi-detached. And in we say that bladder and bowel, they live in a semi-detached house. And if one makes noise like constipation, other one will get disturbed. And people immediately get an idea they need to address their constipation. Give advice about incontinence pads. As I was saying, Akshay Kumar's Padman, yes, something is there. There are washable underpants available, because the dry cotton pads which people are using, very often they can rub against the vulval skin, make it sore. On top of it, the nitrates in the urine, they can also make it all vulval irritation. Instead, there are underpants available which has got incorporated pad itself. So, and they can be capacitating from 10-20 mils right up to 200-300 mils of urine can be contained, and they could be quite good. And they're washable. You don't need to throw it away. So that is something which can be looked at. I'm not sure whether such things are available in India or not, but that is something I would like to share. Improve mobility and toilet access. People, they are frail, they can't walk fast enough, especially at night. And here in UK, more houses are two-story, and the toilet usually is upstairs. In modern houses, there could be toilet downstairs. When you tell them for mobility that, why don't you use a walking stick? But it comes too much of pride. No, no, I'm not old woman at 80. What do you say? And when you say about toilet that, well, in the middle of the night, you need to go upstairs and you are at risk of falling. And they say, oh, no, doctor, I can manage. And when you suggest that, why don't you keep a commode? Because now commodes are available. They are so discreet that they are not sort of so visible. They look like a chair only. Oh, no, no, I'm not going on that. Well, again, so those simple measures and education will help. Recommend HRT, as I mentioned. Lack of estrogen can irritate vagina and the bladder. So simple things, remember just 4 C's. I know all the women will be thinking about 4C of diamond, clarity, carrot, and so on. But these are the 4 C's for continence. And if you want to maintain your continence, cough, control it, caffeine, control it. And I know in India, we don't have such high quantity of caffeine. Here, cup of tea and coffee is so common. People use it 8, 10, maybe up to 15 times. And the cups here are not like nice small Indian one. Here they are big mugs, about 200 mils, 300 mils, big one. So you can imagine. Constipation, and lastly, calorie, obesity. So treat them hard. So 4 C's, whenever you think about wearing diamond, make sure you have to educate 4 people about cough, caffeine, constipation, and calories. Pharmacological agents. Now, if simple measures don't give good results, you go on the next step. The very clear guidance for managing overactive bladder and so on is, number 1, you go simple measures. Number 2, you go medication. Number 3, you go on invasive treatment, investigations such as Botox and so on, or PTNS or sacral modulation. So in pharmacological treatment, oxybutynin, age-old, and I do remember 40 years ago when I came to this country, this was the only drug. Now, since then, fortunately, we have got so many of more medications available. Sulfenacin, it's anticholinergic, and you give it in dose of 5 to 10 milligram. Tolterodine, which is again in 4 milligram. Toviaz, which is physioterdine, 4 to 8 milligram. Trospium chloride, which is 20 milligram. Propivarin, 50 milligram, you can give up to 4 times a day. And antispasmodic fluvoxamine has some role, not all. And tricyclic antidepressant, people don't believe that it helps, but it does help in sleep, and that's how it does help to have reduced nocturia. And finally, the new drugs, mirabegron, Betmiga, which is the beta 3 antagonist, and that does help. The main problem, and this is much more relevant for elderly patients, is the side effects. The simple things are dry mouth, esophageal reflux, and constipation, headache, dry eyes, and drowsiness, and it can exacerbate the narrow angle glaucoma. And this is quite important. It's narrow angle. It's a closed angle, which you can't give. If it's an open angle, it's not bad. Not advisable in children, and liver disease or their contraindication. In nocturian frequency, imipramine and desmopressin, they can be given, but blood pressure needs to be measured. There's something called anticholinergic burden or cholinergic burden, in which there are so many drugs which are also compounding the effect of anticholinergic medications, and that is where the use in elderly need to be restricted. So let's see how antimuscarinic or anticholinergic helps AMS, how they affect the lipophilicity. So this is the basic neuron structure. and blood-brain barrier is there. Sorry, the photographs are covering some of the writing. Shall I just see if we can reduce it to one and people can read it? Is that better? Okay, so in blood-brain barrier is a dynamic membrane at the level of the capillaries, and this is where blood-brain barrier takes place, and the junctions are tight. However, the antimuscarinic, they can cross the blood-brain barrier via passive diffusion. Now, the ability to cross is causing the cognitive impairment. And this is where we need to be careful, especially in elderly. There's a concern, particularly in elderly, and lipophilicity and molecular size that determines how easily antimuscarinic can cross the blood-brain barrier. Now, lipophilicity, in simple word, is capacity of a medication to get dissolved in oil. And this is where, if they dissolve very quickly, they are likely to be transferred to the brain very quickly. If their molecular size is small, they can escape the tight junction of capillaries as well. Some of the antimuscarinic, they leave the brain via passive diffusion. So similar mechanism to the entering. However, there are some which can be removed from the brain via active transport, and that is the PGP, which is permeability glycoprotein. They get on back of it and they are out of brain. But this is the most important thing to remember really when we are treating elderly. In aging brain, the permeability of BBB is not uniform. It is not stable throughout the life. And in elderly, it could be more impaired with increasing age, certain medication, as I mentioned, stress, comorbidities like Alzheimer's and dementia, Parkinson's, and type 2 diabetes, which is quite common. Particularly in elderly, all the antimuscarinic should be considered to have potential to cross and compromise the blood-brain barrier and gain access to CNS. Physiotyrosine has got low lipophilicity and its substrate PGP transport is there. So it is a little bit better than the other one. Now, the AM lipophilicity, substrate, these are the various medication. With oxybutynin, there's a very high dissolve in the in oil, so it has got very much side effects, and there's no active removal mechanism. Compared to that, physiotyrosine has got low to moderate lipophilicity, and it is probably better because it can be removed by physical or physiological mechanism. So we should not take assumption that there is a relative impact on CNS because of the anticholinergic or antimuscarinic. But out of all the medication list, oxybutynin, sulfenacin, and tolterodine, they probably are the highest in the damage. However, physiotyrosine and trospium. So if you need to take the message or make a note, physiotyrosine and trospium are relatively safe medications out of anticholinergic. By the way, I don't have shares in any of those companies, but this is the research which I'm talking about. There was a FORTA trial, so that is a fit for aging process in lower urinary tract symptoms. So there are international interdisciplinary panel, and they do have classification set out. It helps to guide physician which one will be more suitable in elder patients. So as I said, physiotyrosine is probably one of the beneficial. You need to be careful with derifenacin, mirabegron, oxybutynin, sulfenacin, tolterodine, and trospium. And don't use oxybutynin at standard dose because it is the highest one which will affect cognitive function. Okay, so let's talk about what are we doing and what are the recent advances. Mirabegron, it's adrenoceptor agonist, and Botox for overactive bladder, and the percutaneous tibial nerve stimulation. So those are came in last 20 years or so, and increasingly using interstream therapy for overactive bladder. Again, we'll talk a little bit more later on. And of course, for stress incontinence, transobturator tape insertion or tension-free vaginal tape insertion. Bulkamid periurethral injection is another one which is least minimal invasive, and it can be helped. Mirabegron, it's a beta-3 adrenoceptor agonist. Both efficacy and side effects wise, they are probably better, and there's a specific interaction at muscarinic receptor B3. 97% bladder, they do have B3 receptor, adrenoceptor, and this is the way it works. So remember the parasympathetic, now we talk about hypogastric. Antimuscarinic, they go and bind and they block the receptor. So once you started the contractions, that is where antimuscarinic will go and start relaxing. Whilst sympathetic adrenergic control, like Betmiga, what happens is it goes and binds even before the detrusor contraction occurs. And that's how it increases relaxation. So I always say in very simple terms for a patient to understand that if you are anxious, very worried, you can take medications and that will help you. However, if you do yoga, probably it will help you to relax even before you become anxious. And this is the anxiolytic drugs, parasympathetic, cholinergic, and this is like a yoga drug, sympathetic, and that's the Mirabegron. Botox for overactive bladder. Now, the mechanism how it works is it's a type A and it's a potent neurotoxins. So it goes and binds to the nerves and relaxes them, and the muscles, temporarily flaccid paralysis of the detrusor muscle, and the clinical effect works in 1 to 3 weeks, and benefit lasts up to 9 to 12 months, and it provides durable yet reversible treatment option. And the people who receive Botox, they are really, really very happy. 90% of them, they feel that they have got new lease of life. I have got now patients who are coming almost every yearly, and the highest one I have got is the 16 years that she is receiving the dose of Botox. When I started in Hull University, I was acknowledged by BBC North, and they made a documentary, and it was nice to share. And what we were talking about in message to the community, this was one way the BBC does certain things, and they had a loud and clear message, no doubt to say that our department was then inundated with so many queries, and we had to deal with the capacity. Repeat injection may be required. Now, the surgical technique includes having the monitor, and it's very, very simple procedure, even simpler than the hysteroscopy. So you pass a cystoscope with the double channel, and you pass the needle for the channel, and then you attach the syringe with Botox, and you pass the small needle up to 4 millimeter, and that can help. And I have got that needle which I can just show it to you. This is the needle which got expired on the shelf, and I got it just for this talk. So this is the needle which you pass it, and at the top, there's a small needle. I'm not sure whether you can see it clearly or not, but it comes out a small needle which is controlled by a lock. And it goes back. So that needle is passed in the channel, and at the end you attach the syringe, and that can then be injected. And you inject at 10 or 20 sites 1 mils of fluid. You dilute the Botox about 100 units in 10 mils, or when it is a repeat dose, 200 units in 20 mils, and you inject 1 mil at each site, avoiding the trigon and ureteric orifices, and that can give a very good relaxation. Hopefully this video should work. Right, it didn't want to work. Let me see if I can find the probably you can see this is how the needle is inserted, and you give 1 mils of fluid at 20 different sites. Right, okay, so that's the video on Botox. Let me make sure that I don't switch off the whole presentation. So what is the efficacy? At 6 weeks follow-up, the success rate was about 90 to 100%, and the bladder capacity increased by 1.5, 62%. The diffuser pressure decreased by almost half, and there was decrease in daytime frequency, nocturia, as well as number of pads used. And this is really a viable alternative to surgery where anticholinergic medications have failed. So to conclude the Botox itself, its potential indication is intractable diffuser overactivity, but we must exclude UTI, otherwise it will cause a lot of problem. It's performed using either rigid cystoscope as a day case, or it can be done in the outpatient using a flexible scope. Self-catheterization may be necessary, maybe 5 to 10% of cases. So in UK, we teach every patient self-catheterizing before doing the procedure. Once they are confident that yes, they can do if it's required, then you do it. Some patients may feel that no, I will do it only if it requires, and then we have to use our own judgment whether to go ahead with it or not. It has got excellent safety and tolerability profile, and effect lasts 9 to 12 months. it may need to be repeated. Percutaneous tibial nerve stimulation, PTNS. It's a nice approved procedure and for overactive bladder, and it is okay for short and medium term. There's no major safety concerns. And this is how it is done. A small needle is inserted at the posterior tibial nerve, and it sends some impulses, and the local reflex mechanism gets interrupted, and it does helps to relax the bladder. It's through the gentle impulses, and it can be outpatient. No anesthesia is required. And when you put this needle, you keep it for 30 minutes, and it requires approximately 12 sessions, each of 30 minutes over weekly interval. And thereafter, it could be maintenance dose. So as I said that, yes, it has got good results. And after 3 months, it requires maintenance dose. Interstitial therapy, this is much more invasive procedure in which sacral neuromodulation is done by inserting a fin into your sacral area. It is for the treatment of overactive bladder as well as for bowel urgency and bowel incontinence. It is placed electrode through sacral foramina, and mild electric stimulation is carried out. Success rate is good, 80% or so. Pain, infection, and lead migrations are some of the problem. So this is how it is done under anesthesia, and the battery is connected, and battery is hide under the skin in the buttocks, and then you have got a remote you can control with it. The battery lasts for 3 to 5 years. The current costing is about 5 lakhs in Indian rupee to 7 lakhs, but there may be a less expensive versions. Some more recent advances. Now, whenever I see this picture, and Madam Ranjana was telling about the Kumbh Mela, and this is the picture which came in the Times of India at Kumbh Mela back in I think 84 or around that time, and I really like the picture. And you can see the saint priest having a mobile phone in those days. Of course, he has got cigarette, which we don't approve, but it is there. And when I was sharing this picture with my cousin gynecologist, Dr. Mahesh Gandhi, who practices in a charitable hospital in Gujarat, his vision in those days, 30 years ago, that Jagdish, I want to have this technology of medicine to every small village and town. And he was trained in Mumbai, but he left Mumbai for a very small place in charitable hospital, and he's serving there. And I'm so proud of him that currently he's treating almost everything, including a 4D laparoscopic surgery, IVF, you name it, even all these new procedures for laser therapy and so on. So it can be done, and the it's not just the organization need to work, it's all of us can work individually. Management of stress incontinence, sling procedure, which I will talk about, which has been now governed or has been banned for time being, bulkamid periurethral injection and devices. Female anatomy, everybody knows, the bladder is very close with urethra, uterus, and the bowel. Birth scalpel suspension is another procedure. However, this is quite a big procedure under anesthesia, financial incision. You access retropubic space, and 2 to 3 sutures on side of bladder, neck are inserted and suspended at iliopectineal ligament. It also helps with suprapubic catheter, and patient can require hospitalization, although nowadays it's not as long, but it could be up to 4 to 7 days and good prolonged recovery. Hemorrhage, infection, bladder injury, and prolapse could be the consequences, but it is a gold standard with 80% success rate. TVT, which you pass retropubic, and the tape goes under the urethra. And in TOT, again, it goes under the urethra, but it is transobturator tape. It is combined with repair or hysterectomy, and non-absorbable Prolene tape is used with 2 large needles. There's a hammock-like fashion, and from groin to obturator foramina, and then it goes on the other side. Hemorrhage, bladder perforations are one of those complications which can occur, and next day discharge is possible with recovery in few weeks. Again, it is standard 80% success rate. It was compared in a big trial in UK when initially introduced about 25 years ago. And this is one of the Monarch tape. And let me see the technique, which I'm sure people are quite aware. So that's the technique which is used for transobturator tape. That's one of the most enjoyable operation we had. However, there has been no pause on using any kind of mesh in UK. So that is the basis of my next talk about non-mesh management of incontinence. The other one which we use is the Bulkamid periurethral injection. A small urethoscope is used, and the Bulkamid material is injected through a small needle, and you make a small co-opting in periurethral region, and you make 3 small pillows, which makes the urethral orifice smaller. Right, coming to now challenges of management. There's a cardiac and respiratory and diabetes. These are the comorbidities: stroke, dementia, obesity, prolapse, pelvic floor, medication, constipation. So these are the things which are very common in elderly. In men, probably it's easier. You can do whenever, wherever. But in women, it's very difficult. So what has changed? Why we are addressing this thing? In last 100 years, this is what has happened. In the past, nobody was bothered. A few drops were here and there. But now, it's a big problem. There's an elderly population now. More and more people live longer and longer. And there is a problem with incontinence. And the patient's choice, of course, they do feel that I must have operation, whether it's available or not. And well, you are in dilemma. What will we do? So this is the epidemiology part you were mentioning earlier on, Madam Ranjana and Dr. Usha. Approximately 53% of homebound elderly, they are incontinent. And when we mentioned that every other house has got this problem, it is very, very true. In nursing home, it's over 50%. In hospitalized, 11% urinary incontinence at admission, and when they go home, 23%. So it actually worsens the admission. So what are the common types of chronic urge incontinence or urinary incontinence in older women? Urge incontinence, where there's an involuntary leakage with sudden strong contractions, and that's overactive bladder. Stress incontinence is involuntary cough, leakage on coughing and sneezing. Mixed is mixture of both of it. And overflow, as we mentioned before, is the involuntary leakage when bladder is overfilled or there is an outlet obstruction. And the functional one is the involuntary leakage because of the cognitive or functional or dementia or mobility difficulties. So this is a small mnemonic which you may wish to think about. Diapers, which are used for incontinence. So D is dementia, delirium, diabetes, and I is infection, inflammation. Think about atrophy of vagina. Pharmacology and psychological is excessive urine output, restricted mobility, and stool infection. Remember the duplex house, sacral nerve root problem. Now, out of all those ones, there are few where you can do something. These are the reversible. Delirium and depression, excessive urine output, you can restrict the fluid. Restricted mobility, you can give some devices like a commode and so on, or the walking frame. Stool infection, treat the constipation. Infection is treatable. And vaginal and urethral inflammation, you can give some estrogen as well. But there are some in which your hands are tied and they are not reversible. These are the detrusor muscle overactivity and underactivity. You can't do much in simple measures, but you can treat with some medications. Urethral incontinence, when there's a weakness, again, you can do periurethral injection or something invasive, more invasive procedure. Urethral obstruction is there as well. Now, there are certain medications, and I have gone through a much more detail about this one. So ACE inhibitor, they can have cough and leads to stress incontinence. Alpha adrenergic agonist and antagonist, they can also lose the tone of urethra. Amlodipine, which is quite commonly used, can cause constipation or lower limb edema, which obviously comes back at night time and you have got nocturia and supine position. Anticholinergic, we spoke about, it can lead to incomplete bladder emptying and constipation. Similarly, calcium channel blocker causes constipation. Diuretics causes frequency. Psychotropic causes retention, constipation, and overflow. Sedative can reduce the movement during sleep, and there's a functional incontinence. And tricyclic antidepressant, again, causes retention, constipation, overflow, and so on. The delirium, if it is there, where they can't find toilet, then they find the call and resolve delirium, or maybe even commode. Poor inadequate food intake, and I mentioned about the fun symptoms, encourage 1500 of fluid. Stool impaction, urinary retention, fecal incontinence. Again, post-void residual urine can help to measure and treat, and local estrogen can help. Psychological depression management, pharmacological, find out which medications are the culprit and can be stopped. Excessive urine output, make sure that the fluid intake is no more than 2 liters. Elevating the leg, especially during daytime, or pressure stockings can help. And abnormal results of treating the UTI, high blood sugar, hypothyroid, and restricted mobility can be helped by bedpans and mobilizer and so on. So in targeted approach, what do we do for elderly? If there's a cognitive impact, if they have got dementia, etc., then have scheduled toileting, give them time, habit bladder training and so on, urge inhibition, pelvic floor exercise, pads, drug treatment, and so on. If they have got mild to moderate cognitive impairment, dementia and Alzheimer, then again, prompting them at time, giving drug treatment, skin care, and so on. And if they have got severe cognitive impairment, then again, you need to get them toilet in time, drug treatment, skin care, environmental or my mirrors, physical assistance, and so on. In behavior therapy, patient's education, as we said, is important, timely void, avoiding log or diary will help. That's what is happening. The efficacy of behavior therapy is, its outcomes are quite good. 57% reduction in incontinence episode and 54% in quantity of urine loss. Any healthcare professional can provide it, and it's simple, inexpensive. There's no significant adverse effect, and it requires patient and caregivers motivation. So key reminders for patient: utilize the incontinence product, skin protections like barrier creams, and change the undergarment, which I spoke about, and avoid bladder irritant fluid. The alternative to conservative management, again, absorbable products, use them only when it is absolutely necessary as a coping mechanism. And the catheter is something which I would like to mention, that it's for women in whom persistent incontinence or retention is a problem, or symptomatic infection can be, again, cause or effect from the catheter. And in women who we can't correct the cause, we can use long-term catheter. So there's an offer support, and that can be done by multidisciplinary approach. And when there was a prospective case series, 70 non-demented women up to 90 years of age, behavioral treatment did help when biofeedback, pelvic floor exercise, etc. were done, and average 5.6 treatment episode, the mean weekly frequency accident reduced, and the patients with mixed incontinence had greater improvement. Degree of improvement was not significantly related to age, duration of symptoms, and baseline frequency. So multidisciplinary approach does help. And even when it seems it's hopeless, probably something can be done about it. And finally, from a grateful patients, and this slide I love, and in so many of my presentation, I always put it because this really reflects the modern management and the patient's perspective and satisfaction. She was a psychiatrist consultant who had to retire because of ill health at 45 years of age. And we did the tape for operation for her. She wrote a 2-page long letter thanking, but the gist of it was, as I performed tango at my forthcoming wedding in December, Reg was the husband, and I will thank you that I will only be stepping on his toes and not peeing on them. So, so that's something which can be done. Yeah, but unfortunately, the baby is thrown away with bath water here in this country, and along with the mesh for the prolapse, they have restricted use of tape for the incontinence. So thank you very much, and I think if there are any questions, I
Doctor,
can.
any role of vitamin D? D3?
Yes, it does help, and there has been a lot of papers, and there's a positive effect of vitamin D, definitely.
Okay.
So what should be the level to be? What should we keep vitamin D level? Because the Indians are always deficit of that.
Yes, I mean, I'm so surprised because you have got so much of sunshine, but the
But our
standard.
skin is not of that. Our skin type is different, so that's why we are not able to synthesize that vitamin D. That is the problem with the Indians.
You're quite right. So I think here in this country, UK, they give it in summer months 400 international unit, and in winter month between October and April, it's 800 units.
In India, 2000 IU is recommended per day.
Yes.
Yeah, which I think probably is the dose which is required there.
So we are also giving the loading dose initially, and then
is Komal there?
I think
Amita?
Dr. Chaurasia, he is there, I think.
So we must take his expert opinion.
Yes, yes.
Dr. Dilip?
Yes, very good and elaborate presentation you have given, Dr. Gandhi. Thank you very much for that. And you have covered everything. You have not left anything for me.
I wouldn't go that far, but it's
Yeah.
very kind of you to appreciate.
Right. If the patient is not responding to it, to the treatment, urodynamic study is required to see where the problem is. And especially I see a lot of patients, they are drinking a lot of water.
Yeah.
When they come to you, they are having frequency. When asked, sir, I am taking 4 liters of water a day, 5 liters of water. Why? Why are you taking so much of water? No, someone has said me to take a lot of water and you will be okay. So it is, so lifestyle modification is very, very important to deal with these kind of situation.
Yeah.
Dr. Komal is there?
Can't see her. Sir, Dr. Lalita Shukla is asking how long we can give physioterdine in an elderly patient, maybe say more than
that's-
60 years old.
Yeah, it's excellent question. The usual trial period is first month. If there is signs of improvement, and that you can judge by giving a bladder diary, that before starting the treatment, what was it, and after 1 month you can judge it. If there's some improvement, you continue for first 3 months. You review at 3 months, and then if there's a definite improvement, this medication, they actually retune the bladder. That's how it works. No good giving it for years and years. So after 3 months, there's some improvement.
उसको थोड़ा टाइम लगेगा.
So you give it for 3 months and review, and if they are benefiting, then I continue it for 6 to 9 months, and then you slowly withdraw. Don't ask them to stop. It's like alcohol or cigarette smoking or tea. Suddenly they will get the deficiency, but instead say you reduce it by missing 1 tablet a week. So in the first week, they take only 6 tablets. Next week, they take 5 days, day after 4 days, and like. So in 7 weeks, they will be off. Now, if symptoms return, then you restart them.
Dr. Uma is asking about the side effects of Botox.
Okay. There are 2 common side effects, which is slightly concern to the patient. One is the bladder relax so much that they causes retention. And in about 5 to 10%, this could be the side effects. And that is the reason why we teach them self-catheterization. The second one is the infection. Because of there is a small amount of retention, there's a high chance of infection, which can occur in 10 to 15%, like any other urogynecological procedures. And obviously, you need to rule out any significant contraindications, such as myasthenia gravis, bladder cancer, infections, and so on.
So someone is asking about mirabegron also, how long we can continue?
Again, 6 to 9 months. And when you are giving mirabegron first month, you must watch blood pressure. It doesn't go wrong in vast majority, but in some patients, it can increase blood pressure. And in Japan, they use dose of 25 milligram. In UK, it is licensed for 50 milligram. And you check the blood pressure once a week, every week. And if it is okay, you continue. You can continue it for a long time, 6 months, 9 months, even a year or 2. Some of the patients, they could be even longer than that.
Dr. Manju Verma, ma'am, would you like to give your comments?
Sorry, say it again.
I was saying to Dr. Manju Verma, ma'am, if she would want to give her comments.
I simply can say it was really a feast to the eyes and listen to you. And so many doubts have been cleared of mine also what to say of others. And really, really very wonderful, Dr. Gandhi. That's all I can say.
Thank you. Very kind of you. Very kind of you.
One question, how would you deal with the constipation caused by these anticholinergic drugs? Because there is poor compliance when they get all these problems.
You are absolutely right. And as I said, British bowel are so lazy, and we do face this problem. People don't like to take it all the time. But there are a couple of tricks which I have dealt with. One is sometimes the constipation is from the higher gut, or sometimes they are just collection in the rectal area and the low area. And I recommend using glycerol suppository. That can help. Now, on one hand, you have created a relief from anticholinergic, and then on the other hand, you are putting fuel in the fire. So the other way to deal with it is to give alternatives such as mirabegron. So if you have tried 3 to 6 months of anticholinergic, nothing works, then give mirabegron 3 to 6 months, doesn't work, do urodynamic assessment. If it does show that yes, there is a definite diffuse overactivity diagnosed, then you can give either PTNS or Botox injection. I hope that answers your question.
What about the laxatives? Do you use laxative?
Yes, yeah, laxatives are that is the first step anyway. I'm sorry, I thought you meant that people they would have used the laxative. Yes, that's the first thing. So you have to balance between two. Now there are different kind of laxatives, as you know. Some are the gut irritant, and some are bulk forming. I find the bulk forming, such as the isopgol, they are quite good. And the diet is quite different, processed diet, meat, etc. in this country, as opposed to slightly different diet in India, which is a little bit more bowel friendly.
Thank you.
Okay.
Thank you.
So there are some more questions. One is from Dr. Asha Rathi, role of anabolic steroid in protein supplementation.
Not to my knowledge, unless there's some recent research. Protein supplement, I'm not sure how it affects the bladder. I'm so sorry.
And I think another question will be taken in next, laser therapy in SUI.
Yeah, sure. We can do that. Yeah, we can do. Right. Okay. So shall we go to the memory lane? Have a
Yes,
little
sir.
fun.
Yes,
So for a few minutes, and then thereafter we will have a 5 minutes of break. Is that okay, Chairperson?
Leela ma'am?
Yeah, I was saying that after this one for 5 minutes, we will take 5 minutes comfort break, and then you can we can start the second session, because I'm conscious that we are slightly late as well. But anyway, so my journey and connection started back in 2006, when my dear friend and my mama invited me in Mumbai Obs Gyn Society to give a talk, and that's where the journey started. It was a wonderful experience, and I must thank immensely to Dr. P.K. Shah for getting me connected with Foxy, which over the years I have really enjoyed. One of the reasons why I use, as you perhaps know, in UK, we get a limited leaves from National Health. So we get only 10 days in a year. And if you attend the Foxy or AICOG, it's a 5 days are gone. But I have always felt that the country which has trained me, I owe something back. And if I can knowledge share, that is my contribution. And this is when Dr. Shah came to UK to visit us. And we had a very good time in casino, as you can see. And obviously he won so much money, and he, as a good mama, lending me some as well. And this is when we went to Kolkata in AICOG with Mrs. Gandhi. And incidentally, Dr. P.K. Shah's wife's name is Anju, and my wife is also called Anju. So whenever we have a social interaction, we have a difficulty which Anju we are talking about. And this Anju, his wife, is my cousin as well, but not related in any other way. And then we had a very good time in Jaipur, where Dr. Anju Soni organized a brilliant function and conference. And I was very pleased to participate. And again, Dr. Shah is there as well. And more recently, we had this Scientific Sangam, or Sangam of the academic activities, as Usha ma'am was saying. And we had dear friend Dr. Pai and Ranjana ma'am. And of course, when you go to Prayagraj, you can't not go to the Sangam. The hospitality was absolutely amazing. And in the morning, 4 o'clock, 5 o'clock, they took whoever wanted to go to the Sangam. And of course, Dr. Shah decided to become a priest on that day. And we had a lovely...
A beautiful picture.
Do you want to see it again? There we go.
Yes.
And we had a dip. We did a shortcut. We did not have a dip, but we had a good dip. And this was one of the function. There were a lot of activities, including public forum, and the hospitality mainly arranged by Dr. Khanna's family was wonderful. And they were last people to take the food, but it was wonderful to know them. And there we go, Dr. Vyas in full moon dancing, and Dr. Shah. And we had a lovely event where Dr. Shah had his anniversary, and we celebrated and lots of fun. And this is what Dr. Khanna landed us into, asked us to dance, and me and Mrs.
So beautiful.
Lovely memories.
Yes.
So we had a lovely time. And Dr. Shah is saying, now at Sogog, stop dancing. And we had interaction. Sogog is in Gujarat, it was in Himatnagar, and dear friend, Dr. M.C. Patel and other participants. And this is the Dr. Mahesh Gandhi, who I was talking about. He has established such a good service in a small district level hospital, charitable hospital, and completely committed. And AICOG Hyderabad, one of the other very memorable place we had. And dear Dr. Sharma, who I interact very often as editor in Obs Gyn Journal. And I did like this Sappho because that gave me a real good feeling. And this is when Dr. Shah had lifetime achievement from Foxy. And it was really, really pleasing day when this ceremony took place. And more recently, I had good interaction with Dr. Ashok Kumar, who organized the Association of Obs Gyn Delhi conference and very kindly asked me to participate. And people who know Dr. Ashok, he is such a gentleman, gentle person, but really, really good organizer. We enjoyed it. And Dr. Madhuri Patel receiving the and this is a and Dr. Pai was there, and Dr. So many people were participating. Dr. Tung was there. And this is the full program. And that's the memory from AOGD. So I think that finishes the first session. Now the second session is very shorter one. So hopefully timing wise we are okay. Is that okay, Chairperson?
Yes, sir.
Yeah,
Still we are okay.
we are fine.
Shall we have a few minutes comfort break?
No, sir, we can.
No, we can continue if you can continue.
Right, okay, no problem. I can continue.
So you can have a cup of tea or something.
Right, okay. I'll just.
If we have a comfort break, then our audience will.
रंजना मैडम इसी में डाल दो थोड़ी कॉफी.
I wish I could. I
Okay.
wish I could.
Okay, we'll have just a couple of minutes.
Yeah.
Sure.
But we can continue chit-chatting, then no problem.
Yeah.
Dr. Komal नहीं है क्या? नहीं है.
Dr. Madhuri also wanted to join. Somehow she's not managed to join.
हाँ, मैंने दोनों तरह का ऑप्शन मैम को भेजा, लेकिन पता नहीं कैसे नहीं मिल पाया.
मैम हो नहीं रहा ज्वाइन उनका ना. मैंने ईमेल भी भेज दिया दोबारा से अभी.
हाँ.
हो नहीं पा रहा.
हाँ.
Maybe some issue with
रंजना
your
मैम,
internet.
हाँ जी.
मैं मतलब 20 मिनट बाद छोड़ूंगी क्योंकि मेरे को एक वेबिनार में को 7 बजे शुरू करनी है.
ओके.
20 मिनट में खत्म हो जाना चाहिए.
खत्म हो
most likely.
जाएगा.
हाँ, अच्छा ठीक है. चल
ये 10 मिनट का है बस.
ओके.
उमा है?
Uma Pandey has raised her hand.
Okay.
ये उमा जायसवाल है तो?
है उमा. मेरा ना वो खत्म, पता नहीं मेरे
कोई और बैठा हुआ है.
इसमें कुछ गड़बड़ हो गया. फोन से ज्वाइन किया अभी.
ये तो सविता है.
उमा
सविता
को भी
is there.
ओके.
क्या हुआ डॉक्टर रंजना?
अरे तुम्हारा नाम उमा जायसवाल आ रहा है.
अरे क्यों?
चेंज करो.
अच्छा देखती हूँ. उमा जायसवाल ज्यादा पसंद आने लगी मेरे को.
2-3 जगह उमा जायसवाल 2-3 जगह है.
हमारा तो एक और क्वेश्चन आंसर में आया है. क्या है? अच्छा, उमा पांडे. अच्छा नहीं, बस ऐसे सॉरी आया. ओके.
कहाँ से देखना है?
हाँ, डॉक्टर गांधी इज बैक.
कहाँ से देखें? अब पे जाएं?
नहीं ठीक तो है. डॉक्टर गांधी इज गोइंग टू गिव हिज सेकंड टॉक.
Second, okay, that's fine. I'm not sure whether there's a different group for the other participant, or this is everybody is on this group.
Like, there is different group also for participants.
Okay, yeah. Right. Thank you.
Ma'am, do you want me to shift all of them to the panelist side?
Yeah.
Okay. I'll promote the attendees to panelist side.
Okay. So that they can also easily ask questions.
Yes, ma'am. They can unmute and ask questions.
What about those who have joined by Facebook?
No, ma'am. We can't take their questions right now.
Okay.
Okay, shall I start now?
Yeah.
Okay, so learning objectives. So again, going back, there's a non-mesh options for stress urinary incontinence. And I'll tell you why we need to look into this one. So learning objective is what is happening to synthetic slings, especially in UK, and what are the current options. We will discuss about non-surgical and surgical option. And we'll talk about what is the efficacy, safety of
Savita, mute kar lo.
And new concepts, and we will talk about take-home message. So I bring warm greetings from my city, Hull, which was City of Culture. In Europe, every year they declare a City of Culture. Of course, now we are out of Europe. Brexit has happened, but this was in 2017. And this is my hospital, Hull Royal Infirmary, and we have got a separate building for Women's and Children's Hospital. So no synthetic mesh. So what option do we have? So in July 18, NHS England decided to put a pause on synthetic mesh and tape, which is done for urinary incontinence and prolapse. And the reason was there were so many complications, and that is where a powerful lobby of patients pushed the parliament to pass this motion. And the debate was not about sling is how helpful, but it was against the long-term problems. And the international safety concern has been raised as well. But the overall benefit of specifically sling outweighs the relative low rate of complications. But UK currently is in pause. So what happens? Synthetic tapes and mesh. Where did we go wrong? Well, it looks like either it was a wrong patient or wrong diagnosis or wrong surgeon. I always feel that the gun never kills anybody. It is the holder of the gun who can kill. And that is what has happened. Because urinary incontinence and prolapse, they were so difficult to treat with recurrence rate up to 25-30%. When the mesh and tape came, everybody started on bandwagon. That's right, let's start. And whether they had training, half training, no training, they just started using it. And that is where lots of complication occurred. I believe still in India, it has been used, but the non-surgical option, we discussed in some detail, lifestyle intervention, physical therapy, pharmacological treatment, and product to prevent leakage. There are some complementary therapy which can be used. So very basic thing about lifestyle. We discussed in detail about bowel habit, how it can be helped, or it can cause problem with incontinence, fluid intake we discussed. Smoking, that increases significantly incidence of stress incontinence and overactive bladder. The weight, there was trial in a very small number, but when there was a weight loss below her recognized BMI, there was 33% weight loss following gastric bypass surgery, and they were cured of urinary incontinence, special stress. There's a significant increase in 1 year incidence of stress incontinence if BMI is more than 30. So we need to watch that figure of 30 BMI. Advise women with urinary urge incontinence or overactive bladder, whose BMI is greater than 30. The exercise of long-term high-impact exercise, gymnastic, and compared to low-impact exercise, swimming, and there's no difference between a high-impact and low-impact. Physical therapies, what are available as a non-mesh option, pelvic floor muscle training, vaginal cones, biofeedback. Now, pelvic floor muscle training, when it was carried out at 5 years, people with stress and mixed incontinence, 70% of them reported improvement, or they were dry compared with pre-treatment. Isolated adverse effect were pain and uncomfortable feeling. Vaginal cones and electric stimulation. Now, the way it works is you put a weight in a small capsule and keep it in the vagina and see how much it benefits. And there are gadgets available with electrode you keep in the vagina, and when you have pelvic floor contractions, it will show up how much you are contracting and how strongly. When it was done, vaginal cones against electric stimulation, there was no significant difference between cones and pelvic floor muscle training group. Similarly, cones were compared with electrical stimulation and there was no significant difference, and adverse effect included some abdominal pain, bleeding, vaginitis, and in electric stimulation group, it was tenderness, bleeding, and discomfort. There was no adverse effect on pelvic floor muscle training. Biofeedback. Now, what is biofeedback? Biofeedback simply is making patient aware where the pelvic floor muscles are. And this is done by giving vaginal probes with EMG electrode and pressure sensitive intravaginal device. There's no significant difference between biofeedback assisted pelvic floor training or pelvic floor training on its own. It's just to make patient aware whereabout is the feedback of the muscles. Adverse effect is very little in vaginal probe. They felt uncomfortable, and 70% reported some pain while straining. Pharmacological therapies, I kept telling about estrogens, which is very, very important in incontinence patients. There's a higher cure rate when estriol was used along with pelvic floor muscle training. And duloxetine, nowadays we don't use it because it doesn't appear to be that efficacy. Significantly greater reduction in leakage episodes were reported in duloxetine compared to pelvic floor muscle training alone. However, side effects does lead to discontinuation. So don't use it as a first-line treatment, duloxetine, but you may offer as a second-line treatment. Product to prevent leakage, there are some mechanical way to prevent it. Intravaginal devices such as continence guard and contrail, metal devices like FEMAssist, intraurethral devices, FemSoft, and there is limited evidence only on efficacy. FemSoft, it does leakage episode lowering. However, the UTI was very common, about 47%, and incidence of insertion of trauma and hematuria. The recommendation is don't use intravaginal or intraurethral devices as a routine, but you can try when there is a failure. The non-surgical option which are recommended for optimal benefit is pelvic floor muscle training. Now, we do talk a lot about it, but not many people are exactly aware how we should be doing it. So it does require doing at least for 3 months duration and 8 contractions 3 times per day. Now, the contractions are 2 different types. You don't need to use any perineometer or any biofeedback for it. Pessary's evidence available does not support that it does help with the incontinence part, although there's some evidence that the prolapse part can lead to some benefit for overactive bladder symptoms or cystocele treatment. A complementary therapy, acupuncture, hypnosis, etc. are not recommended. The surgical option, we discussed about periurethral bulking agent. The other ones are autologous sling and Birch-Corpus suspension. And there are a few new concepts like laser therapy, radiotherapy, Visire, and regenerative medicine. Anti-vaginal repair is not truly for incontinence management, and vaginal approach slings such as Pereira, STEMI, RES are tried in the past. And TVT, as I said, that is still used in some countries. Periurethral bulking agent, I showed you in the previous slide that at 3 places, polyacrylamide 0.5 mils is injected, and it aims to restore the closing pressure. Again, this is the way Bulkamid is given. This is the internal sphincter, and you enter with a needle and you inject, and the end results where there's a nice coaptation. The current evidence, it does show that there's a short-term efficacy. Success rate is about 50-50. It's not the best one in that sense, but it is very simple, can be done within 5 minutes or so. The objective cure rate is about 50 to 60%. There are few adverse effects, and that include dysuria, hematuria, frequency, acute retention. So the recommendation is consider it if conservative management has failed. The next one is the autologous facial sling. So when there's no the synthetic sling, this is something which can be used, and it is similar to TVT, where autologous facial sling is put under the urethra, and it has got good 90% success with 3 to 15 years follow-up. Morbidity, where you are harvesting facial sling, should be considered. Either you take it from abdominal wall or from the thigh. The complications include urinary urgency, difficulty passing urine. They are all about 10% or so, damage to the urethra, and wound infection. There was trial comparing autologous sling with Birch corpus suspension, and it showed that retreatment rate was at 5 years in 4% of cases in sling, whilst about 13% in Birch corpus suspension. So from this trial, you can conclude that probably sling, autologous sling is slightly better. Porcine dermis has been used as well, but it doesn't show good results. So this is harvesting the sling from the rectus sheath. You take approximately 8 to 10 centimeters long and about 1 to 2 centimeter wide strip of rectus fascia, and then you place it just like TVT under the urethra. You fix it up, making sure that when you pull the thread, it is properly secured. Birch corpus suspension, I mentioned in the previous one, details of it. And it is a much more complex operation. Just to catch up, this is the at the paraurethral region at the junction. You put a couple of stitches on each side to lift up and put it in the Cooper's or pectineal ligament. And the nice guidance is that Birch corpus suspension and sling should continue to be recommended. And at the moment, synthetic tapes are not acceptable. And don't offer laparoscopic corpus suspension routinely, but it is also available as an alternative. It basically requires experienced laparoscopic surgeon, and working in MDT, multidisciplinary team, will help. Surgical options on TOT, the new concept are laser therapy, radiofrequency, VISER, and regenerative medicine. So what happens to the laser-based devices? Somebody did ask a question, and I hope this presentation will answer some of the question. So it's a high-intensity focused ultrasound, and it's a minimal invasive and minimal painful, and it's a CO2 laser, which is very precise, and it's supposed to thicken the vaginal mucosa, restores elasticity and moisture. Now, you can have thickening by giving estrogen, but it is restoring elasticity is most important. And there's neocollagenesis, and there's a good vascularization. There's excellent patient satisfaction, but it is not approved in America by FDA. Energy-based devices, they are very simple to operate, and there are commercial, very many machines available. They do have thermal actions, and that they shrink mucosa and supportive tissue. Mechanical pull of deeper tissue following shrinkage, and that is neocollagenesis, and that increases elasticity, thickness. The use of laser treatment of female has been described in 7 trials, and that does show, after follow-up of 5 to 36 months, improvement rate of 70 to 80%, 60 to 80%, and then no major adverse reaction. There's minor side effect of sensation of warmth, increased discharge, transient urge urine incontinence. More rigorous trials are required, and currently in UK, there's a very limited commercial use. Radiofrequency treatment using electrode, and this is what is carried out, and that causes external urethral meatus. The local temperature increases, and that enables vasodilatation and improves drainage. This can improve the circulation, and it contributes in urethral closure mechanism. The treatment of stress incontinence with radiotherapy, there has no real adverse effect. And after 1 month, when PET test was done, there was a good reduction, and satisfaction was about 90% also. Intraurethral or intravaginal probe, they do have diathermy process resulting in retractions of existing collagen. The other one are the non-ablative radiofrequency external urethral meatus, and Wizz Air intravesical. It's like a little balloon, and it's placed and compared with placebo, and it had about nearly 60 to 80% improvement compared to 20 to 30% with placebo. There were no treatment-related serious incidences, and it was less invasive treatment option. The regenerative medicine, it's in infancy, but it halts the disease process and restores some of the continence mechanism. Its multipotent mesenchymal stem cells are isolated from bone marrow, and there's a short-term safety and moderate efficacy results are there, compare or even worse to those published on conventional urethral bulking. Cell-based therapy has demonstrated safety in short term, but does not support its strong or durable efficacy conclusion. So take-home message from this non-mesh management and nice recommendation. So when you are offering surgical procedure, discuss risk of different treatment for stress incontinence. If there's a conservative management has failed, then periurethral bulking agent or autologous sling or couple suspension may help. Synthetic mid-urethral tape, if you are allowed to use, you are lucky, but there are current restrictions in UK. There's a laser therapy, radiofrequency, intracerebral balloon, and stem cell therapy. They're all in infancy. And if you can't deal, please refer it to alternative surgeons so that they can look after the woman and offer alternatives. Offer a follow-up appointment within 6 months. And nowadays, with so much backlog from COVID in national health, instead of face-to-face, we have started doing telescopic or telephonic follow-up. So patients are phoned and find out if there's problem, then we can see. So joy of life for people who have got tape forever. The overall benefit outweighs the relative risk very much. As I said, that we have, I think we started at 11:15, 11:30, so a couple of hours of talking. And we'll take 2 questions.
Dr. Gandhi, I wanted to ask that there are these chairs that have come up, this cosmetic gynecology. They have got these chairs, and you are supposed to sit on the chairs for half an hour, and they cure you of SUI. I mean, what is your take on that?
Ma'am, वो तो electromagnetic chair है.
Electromagnetic.
That gives the Kegels. वो आपको जो thousands of Kegels करवा देगा.
अच्छा.
That gives आपको muscle power वो है. It's not that it will take out that SUI.
हाँ, SUI तो will remain.
तो मैम SUI के लिए तो कुछ Kegel बताते हैं ना. तो वो Kegel करवाता है. Electromagnetic chair.
It is just for Kegels.
करवाना है क्योंकि otherwise Kegel 10 Kegel करने में patient का हो जाता है.
हाँ.
Urinary incontinence due to laxity or rectal incontinence due to laxity?
It is supposed to improve
with
because
this.
it is resulting into the minor,
Nowadays, Dr. Gandhi, it's very popular in India.
Yeah, ma'am.
It is very popular, it is commercialized, and sometimes you can say that people who do not know whereabout is the pelvic floor muscles, and they will say, oh, I go, I do yoga, I do Pilates, I run, but it's the pelvic floor which needs treating.
Yeah.
And simple exercise. Fortunately, we
perineal
have
strengthening is a thing which can improve some problems of the patients.
definitely.
Yeah.
So,
And what about collagen injections?
collagen, yes, that's itself collagen. We use it here, Bulkamid, which is
PRP.
acrylamide. Collagen itself, I'm not sure whether that will do any good because it probably will get absorbed very soon as well.
What are these bulking agents that you were talking about?
It's the polyacrylamide. It's a 2.5%. It is the like a I wouldn't say gelatin, but it's a synthetic material. And when you inject, it does close down or narrow down the urethra. It does get absorbed, unfortunately, sometime in 6 months, 12 months. But by that time, so many patients, they feel that they are much better and probably they can cope thereafter.
Okay.
Sir, what is your take on PRP?
Tell me PRP, what's PRP?
Platelet-rich
Platelet-rich
plasma
plasma.
proteins.
Okay, okay.
That
Yeah,
contains
no,
stem cells actually.
yeah, it's a stem cell and then so on. We don't have that facility at all in UK, and I can't say that there's a lot I can say about it. I got no practical experience, and all in the books. So I wouldn't.
Okay. It's been used in India. People say they're benefited, but long study reports have to come in.
In SUI?
Yes, ma'am.
Yes.
So I think probably India is following two models. One is UK model and another is American
US
model.
Yes, sir.
It's I mean, I do read in literature and so on, all these things, but as I said, that I do not have first-hand experience, and I can't make judgment that yes, even all this laser therapy and
G-spot, O-spot, yeah.
they are very, very few in UK. UK, as you can see, that very well-established procedure like synthetic mesh that has been thrown out because of this kind of scenario and so on. And they are not looking at the brighter side that how many people got benefited. So here, adopting a new technique is really going through all sort of hoops and loops.
Yeah. I
Here
think in
in India,
Britain they are more rigid and more conservative, like more, what can I say? Yeah, rigid only I can say in their views.
Yeah,
No,
you don't
They
get
prefer, ma'am, they
he
don't
fears
go for
rigidity.
surgery. They don't prefer surgery
Yeah.
in India.
In India?
yeah.
Okay.
I mean,
in India, we still use meshes.
Yeah.
that's right. Yeah.
And people are very happy with it.
Yeah.
And it has got good results, and that's why I say that.
Yes, sir. It has got.
Yeah,
Even in
and
US, I think even in US it is being used.
I'm not sure about US because there is so much litigations, and some
Okay.
of the
Yeah.
companies are already closed down. But the results, and I was quoting that it's really the baby has been thrown with bath water because there has been few complications and few powerful lobby. People have completely put a pause on it,
Yeah.
and they haven't seen that what is actual benefit and what is the cause for it. And in limited centers, they are allowed. Now we have got in UK specialist MASH centers.
Oh.
Yeah, so that if there's any MASH complication from previous cases, we refer to the MASH center and then they deal with it. There has been a very big how about the MASH and its consequence in UK. name MASH is almost sort of seen as a sin. So nobody talk about.
And autologous grafts you all are using?
Yes, it's a very autologous graft is very good. It's an more invasive surgery, but it's excellent results. Very good.
So you take graft from where?
From the
Rectus sheath.
or sometime in US, fascial graft is quite common.
Yeah.
But in,
We have exhausted you, Dr. Gandhi, today.
sorry, I did not hear Madam Ranjana.
I'm saying we have exhausted you today.
No, don't worry about it. I have enjoyed it thoroughly.
We have also enjoyed.
Yeah, I will stop sharing so we can see everybody now.
Yeah.
And yeah, I mean, I always feel that when there are not questions, that means everybody has understood everything, or nobody.
Or nobody is
nothing.
Or nobody was listening.
Understood anything.
We had few questions.
So nice, so nice. That's really so nice to hear you.
No, it's lovely. I really enjoyed, and once again, my good friend Dr. P.K. Shah, thank you very much for putting me on the platform. I'm still dancing on it.
I would like to say one thing, Jagdish.
Sorry.
We enjoyed both the talks, excellent talks, and we had fun. Not the one which you talked about, but in reality, we had fun. And it's so nice to hear you on fantastic way, the way you put it. I think all those people who joined must have got at least some message from your talks, and they will put it into practice.
Hello.
So thanks a lot, and all my wishes to you and the family, and we'll meet after 2 weeks.
Certainly, yes.
Yeah.
I look forward. Yes, no, it has been great talking. And I think what happens is when you are given 15 minutes, 20 minutes, 30 minutes, you are constantly worried about rushing and so on. Here, I really felt that I truly was able to give not only message, but the rationale behind it as well. And that's what makes more enjoyable for mine.
Great teaching.
Verma ma'am, namaskar.
कैसे हो आप?
बस मजे में.
अच्छा लगता है आपने को देख के बहुत अच्छा लगता है.
Thank you.
Amita.
Thank you so much, sir. And I would request my dear friend Dr. Uma Jaiswal to post the vote of thanks.
Thank you, Amita, and good evening, everyone. After a very informative talk of 39 edition of Scientific Sangam, organized by ISOPARB Prayagraj in collaboration with AOGS on Masterclass on Urinary Incontinence, what you always wanted to know. First and foremost, thank you, Dr. Ranjana Khanna ma'am, organizing chairperson and organizing secretary, Dr. Amita Tripathi, to organize this important topic or webinar on a very important topic which spoken too less. Thank you, Padamshri, Dr. Usha Sharma ma'am, as a chief guest to give us blessings and shower of love on us. Thank you, Dr. P.K. Shah sir, and Madhuri Patel ma'am. Maybe she is not able to join, but thank you. She is Secretary General Foxy and sir is past president 2012 to as a guest of honor of today's session, and this graced this master class and gave your words of wisdom. Thank you, sir. Thank you, scientific expert as our own Professor Manju Verma ma'am. She is always flooded with advanced knowledge. Thank you so much, ma'am. Thank you, Dr. Dilip Chaurasia sir, Professor Urosurgery, General Medical College, as their expert comment. Thank you, Chairpersons, Dr. Leela Vyas ma'am and Dr. Komal and Chauhan, please VP Foxy Elect, for their valuable inputs on a very important topic. Thank you, Dr. Jagdish Gandhi sir, as an international speaker.
Most
You are
important.
giving a complete knowledge and justice to both the topic. Thank you,
Yes,
sir,
we
for
really
very
enjoyed.
informative talk.
And ICOG, and you must thank Dr. Deepika Chhabra also.
And thank you, ICOG, for giving us 2 ICOG points. Always they give us point in a one day when we send the message. Thank you, ICOG. Dr. Shiva Pandey ma'am and Dr. Kavita Varanbal, Chairperson, Urogynaecology and Pelvic Floor Repair Committee. Thank you so much. Last but not the least, thank you the audience. They listen patiently for a long but very informative talking. Thank you. Thank you, my co-convener, Dr. Parul, for helping me. And question answer are very good for the buttocks and everything. Very good. Thank you, Dr. Deepika, for arranging us, always with us for this webinar. And it is very smoothly running. Usually we see something is problem is there. Thank you so much, Jagsonpal, for giving us this platform. Thank you, everyone.
I just minute to just showcase 2 or 3 of our products. We have recently launched FE protein, the perfect companion in pregnancy. With the benefits of lactoferrin in pregnancy, you can start this tablet from first trimester until delivery. FE protein newly launched, lactoferrin plus ferrous bisglycinate, vitamin B6, folic acid, B12, and veg vitamin D3. Apart from this, our very old Doxypal DRL, the 100 mg doxycycline capsule, which has the benefit of lactobacillus, lactic acid bacillus, and Cystelia-M, the right combination to restore reproductive health in the ideal ratio of 40:1, myoinositol and dechiroinositol.
Thank you, Dr. Jagdish Gandhi, for this lovely, lovely master class. And words are insufficient, and we really enjoyed ourselves. And I learned a lot today, I must say. The small tidbits that you tell are very good, actually. So you have to be very attentive when you are talking so that we can catch those points.
Well,
And thank you, Dr. P.K. Shah sir, for staying till the end.
My pleasure.
Thank you. Till we
Thank
meet
you, everyone. Thank you,
Bye.
sir.
Mumbai.
thank you very much.
Thank you.
So we
Thank
close
you,
the
sir.
meeting
Thank
with
you, sir.
information now, ma'am.
Yes, yes,
Bye-bye.
Shall we leave now?
Bye-bye.
yes.
Thank
Yes,
you
sir.
so much.